So I'm going to go ahead and get started, and the talk I'm giving today is about delirium, both identifying and the management of it. No particular disclosures. These are the objectives that we'll go over. And we'll start off by defining delirium. And actually, it's a DSM diagnosis or definition. And based off the most recent DSM V, there's 5 key features to look for. There's disturbance in attention and awareness. It has to develop over a short period of time and represents a change from baseline and tends to fluctuate during the course of the day. And additionally, there has to be an additional disturbance in cognition. These first 3 points are important because later on we look at the tools that are used to diagnose delirium in the ICU. They use these features right here. Additionally, disturbances cannot be explained by other pre-existing or neurocognitive disorders, and they basically, patient has to have some level of arousal. They can't be comatose for you to make this diagnosis. And there has to be some evidence in history exam or lab findings that suggest that disturbance is from some sort of medical condition or substance or drug. Clinically, this is the breakdown. We tend to think of delirium in the ICU as basically being these patients who are agitated. They're pulling on lines. But that's actually the small subset of patients presenting with delirium. It's only up to 2% of cases that patients present in this hyperactive subtype. The majority of patients are actually down here. They're the mixed of between the hyperactive and the hypoactive, or just flat out hypoactive. And you can see it's almost 98% of patients fall in this these 2 categories here. So with regard to the hypoactive subtype, these are the patients that we tend to term, they're encephalopathic. They're just not themselves. They're withdrawn. They're flat. They're just not as responsive. But we tend not to think of them initially as being delirious in the ICU. Importantly, as you would expect, it's under-recognized. So this subtype is very under-recognized. It's more frequently seen in an older population, and importantly, it has a worse prognosis. So comparing 6-month mortality between the hypoactive group and the other subtypes, there's almost an absolute difference of 20%. So 32% compared to around 9%, which is pretty significant. As far as the epidemiology goes, the incidence is very high in the ICU population, and as you would expect, this is more so in the ventilated subset of ICU patients. So up to 80% of those patients who are mechanically ventilated tend to have delirium, and less so the patients who are not on mechanical ventilation. Pathophysiology is complex, not completely understood, and there are a lot of hypotheses, so I won't belabor the point and spend time on that. As far as risk factor goes, there are many, but it's nice to break them down into what the potentially pre-existing risk factors are coming in, and what are some of the things that can precipitate them. So precipitating risk factors and pre-existing risk factors. And I'll highlight age, severity of illness, and then some of the more iatrogenic causes, and I'll highlight benzodiazepines here. And you can see on the right, plotting both age, disease severity, and benzodiazepine against, on the y-axis, the probability of transitioning to delirium. You see, clear rise as you go along the x-axis. With regards to the diagnosis, we can't just take the DSM definition and apply that in the ICU. So we have tools that we use and apply in the ICU to make a diagnosis of delirium. There are 3 validated instruments that we can use in the ICU setting. The most commonly used is the CAM-ICU, which stands for the Confusion Assessment Method for the Intensive Care Unit. The second one is the Intensive Care Delirium Screening Checklist, or the ICDSC. And then there's also the Nursing Delirium Screening Scale. So these are, again, validated for the ICU setting. The CAM-ICU is the most extensively studied and validated out of the 3. And it's been specifically validated in nonverbal ventilated patients. And it has an excellent sensitivity and specificity for this purpose. This is the breakdown of what the CAM-ICU is. And again, it goes back to some of the features of the DSM definition of delirium. And so there are 4 features that basically make up the CAM-ICU. To make the diagnosis, you need to have the first two features present and an additional feature of either 3 or 4. And so they read out as follows: an acute change or fluctuating course of mental status with inattention and either altered level of consciousness or disorganized thinking. So you need to have 3 components with the first 2 being present as well. This is the RAS scale, and this is important because the CAM-ICU utilizes the RAS scale to assess feature 3 and to even determine whether or not it's feasible to do a CAM assessment to begin with. And I'll just highlight that 0 is alert and calm. As you go up in the scoring system, you're talking about more sort of hyperactive behavior. And as you go down the negative scale, you're talking about patients who are drowsy all the way to comatose. In negative 4 and 5, these patients need physical stimulus to be aroused, so they're almost comatose or stuporous. Anything above that, you're talking about verbal stimulation to arousal. And so the reason this is important is because when you want to apply the CAM-ICU to a patient and do an assessment, you first want to start off with assessing the RAS score. Because if the patient falls within a negative 4 or negative 5, and you can't arouse them except with deep stimulation or they're unarousable, you can't do your assessment. So you can't assess patients who are below a negative 3. However, if they're above a negative 4, you can continue with your CAM-ICU assessment. And the first feature, again, is the acute onset or fluctuating course. So what you do here is you do an assessment of whether or not there's been a change from baseline in the past 24 hours or a change from what they were before their admission. So those are the 2 ways to look at it. And you can use the RAS or GCS score, but typically the RAS is used. So you need that. If that is present, you go on to the next part, which is feature 2, which is inattention. So again, you're dealing with ICU patients who are nonverbal, they're ventilated, so you need to have a way of assessing things nonverbally. And so the way to administer this would be to have a patient squeeze their hand every time they hear the letter A as you spell out this statement, save heart. More than 3 errors is a positive finding. So then you score for both feature 1 and 2, and you move on. To make the diagnosis, you need to have either feature 3 or 4 present as well. So the easiest way to approach this is to then look at your RAS score, and if the RAS score is anything other than 0, you made your diagnosis of delirium because you have feature 1 and 2 present and now feature 3. If, however, your RAS score is 0 and the patient is calm, then you have to assess whether or not there's disorganized thinking. And you do that by asking a series of questions for which the patient is able to answer. And more than 1 error on this signals that there's disorganized thinking, and that allows you to make the diagnosis. So these are the 4 components. You need to have the first 2 as a requirement, plus feature 3 or 4. We'll go over some of the studies that sort of helped validate the CAM-ICU. And this first study basically was developed to validate this tool and to help accurately diagnose delirium in ICU patients who are, again, typically nonverbal. So this is the first study that actually developed the CAM-ICU. Before the CAM-ICU, there was just the CAM, and that was just used basically in patients who were able to verbalize. So what this study did was they took those verbal components and they substituted them with nonverbal assessments. So again, squeezing the hand or nodding and things of that nature, so you could apply it in the ICU setting for patients who are nonverbal. So the way the study was designed was it was a prospective cohort study, and they did daily ratings of the modified CAM. And they had 4 evaluations every day. So they had 2 nurses, an intensivist, and then sort of the gold standard they used, or the comparator, was an expert in delirium, who was basically a psychiatrist, like a geriatric psychiatrist. And they took all of those assessments, and they applied the subset of patients that they evaluated here were all comers into the ICU over a 3-month period. And so what you find here is very high sensitivity, specificity, and inter-rater reliability across the nurses, the intensivists, and comparing those to, again, the standard of the geriatric psychiatrist. So this was sort of the first study that showed that this was validated in the ICU setting. And again, you see they break it down into patients who potentially had suspected delirium. Patients who were older, patients who were mechanically ventilated, and across the board, you see that the sensitivity, specificity remains high. The next study was done by the same group, and this was back in, again, 2001, and this specifically sought to validate it in ventilated patients. So the first study looked at all comers in the ICU, ventilated and non-ventilated patients. So this subset was strictly patients who were on mechanical ventilation. And they sought to validate the CAM-ICU in that subset of patients. And again, as a prospective cohort study, they enrolled 111 patients, and what they found was similar findings to the earlier study: high sensitivity, specificity, and interrelated reliability. And they found that the prevalence of delirium in this subset of patients was almost 83%. And again, similar findings to the earlier study. So it's just a bigger number focused on patients who are mechanically ventilated. So now that we know the definition, we know how to diagnose it using simple tools in the ICU. The question becomes, well, why does it matter? And the easiest way to think about it is in the ICU, we tend to break down the human body into organs, and we sort of count the number of organs that are in failure or in dysfunction, and we typically discount the brain as an organ. But delirium is organ dysfunction. It's organ dysfunction of the brain. And so it's been found time and time again that delirium is an independent predictor of the following: mortality, prolonged length of stay both in the ICU and in the hospital, days on the ventilator, for self-extubation, removal of catheters, for reintubation, cost of care, and decreased long-term cognitive function. So quite an impact. This next study here basically, again, is part of how we derived some of these outcomes that we found delirium has an impact on. And so this was a 2004 JAMA study, and it sought to determine if delirium is an independent predictor of clinical outcomes. And it was a prospective cohort of consecutively enrolled mechanically ventilated patients who were evaluated by the CAM-ICU. And so what they ended up finding in the study was a higher 6-month mortality with a hazard ratio of around 3.2, that the number of days spent in a delirious state independently predicted mortality as well, and that delirium was independently associated with ICU length of stay, hospital length of stay, duration of mechanical ventilation, and cognitive impairment at hospital discharge. And so this is sort of breakdown of the data, and you see, the two arms of delirium and no delirium, and mortality, hospital stay, and post-ICU stay with significant findings and significant p-values. And this is breakdown, and you see the clear breakdown of the Kaplan-Meier curves with survival, and I'll just focus on this one here. This breaks it down further into patients who ended up having a component of coma as well. This breaks down length of stay, and you see a clear breakdown in patients who were not delirious. And this study also looked at the administration of sedative drugs in the ICU, and what they found was that there was a significant association between the use of lorazepam and the development of ICU delirium. And this wasn't found with propofol, morphine, or fentanyl. This next study basically sought to determine the relationship between the number of delirium days and clinical outcomes. And this was a 2010 study in critical care medicine. And it was a prospective cohort study that used the SEDCOM trial. And we'll talk about the SEDCOM trial in a little bit. But the SEDCOM trial was briefly a trial that broke into two arms of Precedex and Versed to lightly sedate patients who are mechanically ventilated in the ICU. And we'll talk about that in a little bit. But this secondary analysis of that study basically found that patients who were delirious had an increase in mortality of 30 versus 11%, decreased time to extubation, and increased ICU length of stay. And so these are sort of the breakdown you see here. This is survival with mortality. This is the duration of mechanical ventilation, and this is the length of stay in the ICU. And there's a clear break in each of those. These are the hazard ratios and they basically break them down into delirium, on the first day, lasting the second day into the third day, and you see that the hazard ratio significantly increases as each day goes along. So now that we know that delirium is an independent predictor of all of these poor outcomes, the next question that arises is, what can we do about this? And so these are some of the things that we need to focus on. Prevention is probably key, and we need to work on modifiable risk factors. The things that we probably have a big hand in is medications, sedatives, analgesics, anticholinergics, and to fix metabolic disturbances and avoid hypoxia. One question that arises is there any role for pharmacological prophylaxis to sort of prevent delirium, since it's associated with all of these poor outcomes? Fortunately, there's been no evidence to support this in the ICU population. There was one study that showed that in patients undergoing elective surgery, I think it was orthopedic surgery, that low-dose antipsychotics reduced the incidence of delirium in those patients. But again, this doesn't extend to the ICU population. So we'll talk right now about pharmacological interventions and some of the trials that we have that, with regards to pharmacological therapies. And we'll start off with the MENDS trial. And that was a 2007 JAMA study that sought to look at the role of Precedex versus lorazepam on the duration of delirium in mechanically ventilated patients while providing adequate sedation. And it's important to know that back in 2007, lorazepam was sort of the standard drug to use as an infusion for sedation. And that's why they compared Precedex with lorazepam. And it was a double-blinded, randomized control study, again, in ventilated patients. And what they found was that Precedex resulted in more days alive without delirium and coma, and I'll highlight that in a second, because they emphasize the and coma part. It's not delirium alone. And that patients who were in the Precedex arm were more likely to be at target sedation using the RASS score. So if they had a target level of, let's say, -1 or 1, they were more likely to be within 1 point of that if they were in the Precedex arm, as opposed to the lorazepam arm. And so this is the breakdown of what they found here. So the patients in the Precedex arm, and they break down to duration of brain dysfunction, which is delirium, and the prevalence of it. And they note that delirium and coma-free, there was statistical significance in the Precedex arm for a reduction in that, as well as the prevalence. However, most of this comes from patients who are coma-free, because if you look at it, there's no statistical significance in patients who for reduction in delirium. It's really driven by being coma-free. So if you break this down into delirium and coma, it's really driven by a reduction in coma. Same thing with the prevalence. So you can't read into this and say, well, perhaps Precedex brought down the rate of delirium. It really seems to have an impact on coma, because perhaps lorazepam was over-sedating patients. This plots out, again, the level of patients who are at their target sedation. And so in the darker graph, patients who are in Precedex are more likely to be at their target level of sedation as opposed to lorazepam. And this breaks down, again, patients being, again, more adequately sedated in the Precedex arm as opposed to the lorazepam arm. However, one thing to know about this trial was that they allowed patients to receive as-needed fentanyl boluses or infusions, in addition to as-needed propofol and antipsychotics. And so they broke down these medications and how they were used, and you'll find that in the Precedex arm, the patients ended up receiving higher doses of fentanyl as compared to the lorazepam arm. And so while the study claimed that Precedex was more effective at getting patients to target sedation, it came at the cost of requiring more fentanyl. So it raises the question of, well, was it really effective at getting patients to target sedation levels? Because you're assuming that this was given because patients were perhaps agitated. As far as adverse outcomes, basically the Precedex arm had bradycardia that was found to be statistically significant. And we talked about some of these caveats in this study. There is an ongoing trial to follow up on that, and it's called the MENDS II Trial. It's expected to come out next year, and that trial is looking at Precedex in one arm and propofol in another arm in severely septic patients who are mechanically ventilated. The next study is the SEDCOM trial, and so this is the trial that we talked about earlier, and it came out in 2009 in JAMA, and it was designed to look at Precedex in one arm and Midazolam in another arm, and looking at efficacy and safety. And so it was designed as a double-blinded randomized controlled trial, and they randomized patients in a 2-to-1 ratio. And they did that specifically because they wanted to better look at the safety profile of Precedex. So two patients went to the Precedex arm, and one patient would go to the Midazolam arm. And they did allow as-needed fentanyl and boluses and haldol, but no propofol in this study. So this study found that at comparable levels of sedation, Precedex treated patients spent less time on the ventilator, had less delirium, developed less tachycardia and hypertension at the expense of bradycardia. And so this is the data that we have for this study, and you can clearly see that there's a difference in time to extubation. The Precedex arm that favors the Precedex arm, ICU length of stay, and as well as the prevalence of delirium in the Precedex arm. So all favorable for Precedex. I will note that compared to the trial we discussed earlier, there was no statistical significance in the amount of fentanyl that was used between the two arms. So a little bit different than the previous study. And this again breaks down the prevalence of delirium as treatment days go along in the Precedex and the Midazolam arms. So you'll clearly see that there's, as the days go along, there's a discordance between those two arms that favors the Precedex. And this again shows that bradycardia was known to be a more prominent side effect. Looking at mortality, while there was a reduction in mortality, this wasn't statistically significant here. The next trial that we'll talk about is the DESIRE trial. And this actually just got published in April of this year in JAMA. And what this trial did was it sought to examine whether a sedation strategy with Precedex can improve clinical outcomes in patients who have severe sepsis and are mechanically ventilated. And the reason they did this was because in animal models, Precedex has been found to sort of have a modulatory effect on inflammation and catecholamine response. And it's thought that perhaps that could temper down some of the inflammatory response in sepsis and maybe have improved clinical outcomes. And so that's why they chose it specifically in sepsis patients. And so it was a randomized controlled trial in, again, ICU patients who were septic and mechanically ventilated. And the two arms were, the one group had a Precedex infusion throughout the duration of the study. This other arm had no Precedex infusion, but both arms could use any other type of sedation that the patient required. So that could include benzodiazepines, propofol, and opiates. What they found was an 8% reduction in 28-day mortality, but this was not statistically significant. I will point out that this study was powered to detect a 20% reduction in mortality, and that was based off of the previous MENDS trial. So we don't know if it was, if it was done a different way and powered to detect perhaps that level of mortality, whether or not we would find that significant. But you could argue that 8% is pretty significant reduction. Yes?
I may have missed it, but how many days on average were those patients who received dexmedetomidine on it?
I can't recall exactly how long, but it was, I can't recall specifically how long they were on it, but I think it was for the duration of their ICU stay. I don't think there was a set date after which they discontinued it, but I can get back to you on that. Yes, Dr. Cook.
A little statistical quirk.
Yeah.
So if the control group mortality is 28%,
Yep.
a 20% reduction of 28% is 7%.
7%, correct.
They showed more than a 7% reduction.
Right.
So
No, it was a 9. So if you look at it, the 19% as opposed to 29%, 28%.
that's 9%.
So sorry, 9%.
That's more than 7.
quoted 8%, I think, as a reduction in mortality.
Both are both greater
Right.
than 7.
Right.
So
Yeah.
it's not a power problem. I don't know why it's not. If they powered it, to show a 20% reduction, they were assuming a control group mortality that was much higher than
What they found.
8%.
Right.
Because they showed a 20% reduction in mortality.
That makes sense, right.
20 is relative, right? It's
Right.
not an absolute.
I'm not sure if they were looking at an absolute reduction in 20. They would know like that? Okay.
It's always relative.
Okay, so that makes sense. So that was sort of the significant finding here, is that there was a reduction in mortality, but they deemed it not statistically significant, and they felt it was because of the way they powered the study. And this was the breakdown if you look at mortality. And as far as adequate level of sedation, they found that using Precedex really didn't have any impact on achieving a target level of sedation in the two different arms. And so that was that study, and that was pretty recent. The next study, sorry.
Did they report how much they used other drugs for sedation?
They broke them down in a chart, yeah.
Was it different?
Between the two charts, no, there was nothing. I would have included if there was a significant. No, it didn't.
So were they using a sedating dose of Dex, or were they using a non-sedating?
They were, but the thing is, it wasn't exclusive to this country. So outside of the U.S., I think the maximum level for Precedex infusions is limited. I think even in Japan they had a limit to what the Precedex dose could be. So I don't think it's the level that we use here, because it wasn't just in one center. So the next couple studies look at antipsychotics. And so the first one basically sought to compare the efficacy and safety of scheduled quetiapine to placebo for the treatment of delirium in critically ill patients who were requiring as-needed haloperidol. And so it was designed as a double-blind, placebo-controlled, randomized control study in patients with delirium who were randomized to receive quetiapine starting at 50 milligrams every 12 hours. As opposed to continuing them on the second arm on just as-needed haloperidol. If patients were found to require haloperidol within the previous 24 hours, the dose was consecutively increased until they reached the maximal dose of 200 milligrams BID. And so what this study found was that adding quetiapine to as-needed haloperidol resulted in faster delirium resolution, less agitation, and a greater rate of transfer to home or rehabilitation. And this is the breakdown of the data. And so you clearly see the time in delirium favors the quetiapine arm, time spent agitated, and then basically looking at discharge data. When it came to mortality, there was nothing there that was statistically significant, but it looked like perhaps there was something that favored the quetiapine arm there. The next study compared olanzapine to haloperidol. And this sought to compare the safety and efficacy profile of olanzapine to haloperidol in treating patients in the ICU who had delirium. And so it was, again, a randomized controlled trial in all-comer ICU patients with delirium. And the two arms were oral olanzapine versus oral haloperidol. And they assessed delirium severity and benzodiazepine use monitored over 5 days. And so what they found was the delirium index had decreased in both groups, as did the use of benzodiazepine doses. But there was less side effects, specifically extrapyramidal side effects with the olanzapine arm. So it was a negative study. This next study is the Hope trial, and this study came out in Lancet in 2013, and it sought to establish whether early treatment with haloperidol would decrease the time that survivors of critical care illness spent in delirium or coma. And so it was, again, a double-blinded, placebo-controlled, randomized controlled trial in mechanically ventilated patients randomized to receive IV haloperidol, 2.5 milligrams every 8 hours, or a placebo of a saline infusion every 8 hours, irrespective of whether or not the patients had delirium or coma. So in a sense, this sought to look at whether they could prevent delirium from occurring. And so what this study found was, the findings did not support the hypothesis that haloperidol modifies the duration of delirium in critically ill patients. And so that's shown here on the graph. Both arms are pretty much, there's no real difference there. And this is the breakdown of the data. No real difference between the placebo or the haloperidol arm. And again, this was in patients, all comers to the ICU who did or did not have delirium. It really didn't matter. They were given haloperidol and followed over for the duration of that study. When it comes to non-pharmacological interventions, we have some better data here. And so this first study looked at the role of physical therapy in mechanically ventilated patients and its role on delirium. And so it was published in Lancet in 2009 and assessed the efficacy of combining spontaneous awake trials, so that's holding sedation to get the patient conscious, with physical therapy and occupational on functional outcomes in ventilated patients who are independent in pre-morbid health. So these are patients who are functional before coming into the ICU with their illness. And so it was designed as a randomized controlled trial of ventilated patients. In both arms, patients would receive a spontaneous awaking trial. However, the difference between the two arms was that in one arm, the intervention arm, you had a regimented physical therapy, occupational therapy program. So it was sort of, they had a set criteria for who could get physical therapy, and those patients would get the physical therapy. In the control arm, it was sort of usual care, which was basically the team of doctors taking care of the patient would, at their discretion, choose when to quote unquote prescribe physical therapy and occupational therapy for patients. So one was streamlined to facilitate earlier physical therapy. The other arm was left to the discretion of the ICU team. And what this trial showed was that patients who were in the intervention arm returned to independent functional status at discharge at higher rates. They had a shorter duration of delirium and more vent-free days. And importantly, it was safe. So the intervention arm did not have any adverse outcome to patients with regards to safety. And I found this interesting. So left to our own, patients were receiving, their first session of physical therapy 7 days into their stay, versus an intervention arm, a day and a half in, they were getting their intervention. So I found that interesting. This was the safety criteria that was used for therapy, because again, it matters to sort of think through which patients can we protocolize to getting physical therapy, as opposed to having a physician determine when the patient should get it. And so this was the criteria that they used. And so they used a MAP blood pressure of less than 65 or greater than 110, or systolic blood pressure of greater than 200, heart rates of less than 40 or more than 130, respiration rate less than 5 or more than 40, saturations below 88%, and these were the contraindications that they had listed. So increased ICP and active GI bleed, active myocardial ischemia. Interestingly, intermittent hemodialysis, but if patients were on continuous ultrafiltration or hemodialysis, they could participate in sort of the intervention arm. Or agitation that needed increased sedative administration past 30 minutes. Those patients basically could not participate in the physical therapy or an unsecure airway. The next study was also interesting. So this was a QI project, and what this did, and this came out I think in a rehab journal in 2010, and what they sought to do was sort of change the culture of how vented ICU patients were approached with regards to many different components, both sedation, physical therapy, amongst other things. And so what they sought to do was, one, reduce deep sedation in these patients. Two is increase the frequency of rehab consultations in patients in the ICU. And three, to evaluate the effect of those two interventions on length of stay in ICU patients. And so it was designed as a 7-month study. The first 3 months was basically education and bringing everybody up to speed, getting the necessary resources in place, followed by the next 4 months where the whole project was implemented. And this specific hospital had transitioned from sort of infusions of sedation to boluses. And then they instituted, again, a set sort of safety criteria for when physical therapy could work with a patient early on in the course of the hospitalization. And what they found was there's a significant decrease in the number of days of benzodiazepine use, lower doses of sedative use. There was improved sedation, delirium status, and improved rehabilitation courses for patients. And at the end of it all, patients were left with a higher functional mobility, and there was a decrease in both ICU and hospital length of stay. So it goes to show that tackling things from a multifaceted approach can have a significant impact on a number of sort of outcomes that we look to in these patients. And this sort of breaks down what we talked about earlier, sort of the difference in benzodiazepine use. Patients, as far as sedation goes, so you would think that transitioning off of continuous sedation to as-needed sedation, that there might be patients who have breakthrough agitation, but that wasn't found, to be the case. Patients were well sedated in both arms, and then the breakdown in delirium really, favored the interventions that were performed in this study, and it was a pretty significant reduction in delirium. So this picture here just sort of says where we want to try and get to. So, this is a patient I think who was 4 days into his hospitalization for ARDS and, hooked up to the ventilator and walking the hallways participating in physical therapy. So it takes that kind of commitment to achieve these kind of outcomes. The earlier two studies, again, just to touch on why I'm going over this is because I found it kind of interesting when our physical therapists come to us in the ICU and run the list through with us as far as to who can and who shouldn't participate with them in therapy. But having a set criteria and going based off of that basically was found to be safe in all of these studies, and again produced all of these beneficial outcomes. And so to simplify it, some studies have used a RASS that's more than 3, because you can't use this clearly in patients who are comatose. I'm sorry, this is supposed to be -3. Moderate ventilator support, so as long as the patient has a PEEP of less than 10 or an FiO2 below 0.6, or if they are on pressor infusions, that there's been no increase in the dose in the last 2 hours. Alternatively, other studies have used these 3 criteria. Patient is responsive because otherwise you can't do therapy with them. Same PEEP and FiO2 requirements, and then the circulatory criteria was the absence of orthostatic hypotension and catecholamine groups. So some studies use different criteria for which patients were safe to participate in therapy. This last study that I'll talk about really bundled everything together. So it's called the ABCDE bundle, and basically if you break down each of those letters, it's the spontaneous awakening trials is the A, the spontaneous breathing trials is the B, the delirium monitoring, and then the early exercise, all combined into this bundle. And sort of implementing this bundle in an ICU is sort of what we're seeking to achieve here, because each one of these separate components has been shown to have beneficial outcomes, so combining them all together is probably the way to go. And so this study basically was a randomized controlled trial in which the 2 arms were patients who were randomized to this bundle versus not. And the bundle arm had, again, this predetermined criteria for what was safe to do. And so for the spontaneous awakening trials, they had the safety criteria. For the spontaneous breathing trials, they had the criteria. And then again, for the physical therapy, a lot of the criteria that we talked about are mentioned here. And so this was sort of, again, nurse and physical therapy protocol-driven interventions. And they basically enrolled their patients and broke them down to the 2 arms. They included both mechanically and non-mechanically ventilated patients in this study. And they basically found that patients were liberated from the vent sooner, had less delirium, and were more likely to be mobilized by the end of their ICU stay in the intervention arm. And this is the breakdown of the data here. And so you clearly see that patients were liberated from the vent sooner. Patients were less delirious and were in the ICU less. With regards to mortality, if you look at the data here, there's a breakdown. There's a clear breakdown in mortality, but this didn't reach statistical significance. But you clearly see a break there. And then the next question that arises is, well, doing all these nurse and therapy-driven interventions, does this end up being safe for the patient as far as, unplanned extubations, catheters, and things of that nature? So there was really no difference in either arm. So it basically suggested that, with those safety criteria in place, this was a safe intervention for patients in the ICU who were or were not mechanically ventilated. This last part is sort of the guidelines that we have. It's the only guidelines that we have. They come from SCCM, and they were last published in 2013. And they deal with not just delirium, but they deal with sort of pain, anxiety, and delirium, sort of the multifaceted approach to managing these patients. But I just took the component of delirium to sort of highlight where the guidelines stand there. And they break that down into different sections. And the first part they talk about is detecting and monitoring, and they recommend routine monitoring. They break down the level of evidence. They do talk about how the CAM-ICU and the ICDSC are the most valid and reliable tools, which we touched upon earlier. And they recommend routine monitoring of delirium is feasible, and that's because in all the studies that were performed, the CAM-ICU only took anywhere from 2 to 3 minutes to perform. So it's a very quick very quick tool to use. With regards to the risk factors, they identified 4 risk factors as sort of being more significant with regards to increasing the risk of delirium, and there were pre-existing dementia, history of hypertension or alcoholism, and high severity of illness at admission. And so earlier on we touched on some of these. Coma was an independent risk factor. The data regarding opiate use wasn't necessarily clear. Benzodiazepine use, they quoted as may be a risk factor, but there have been other studies that have clearly showed benzodiazepine use, specifically lorazepam, as being an independent risk factor for the development of delirium in the ICU. There was nothing specific with regards to the use of propofol. When it came to Precedex, they found that in mechanically ventilated patients, Precedex infusions for sedations may be associated with lower prevalence of delirium as compared to benzodiazepines. And we touched based on 3 or 4 studies that looked at Precedex, and it seems that a lot of the outcomes look a little positive for Precedex, but not everything sort of aligns. With regards to prevention, they recommend early mobilization. We saw some studies that looked at that. They provided no recommendation for pharmacological delirium prevention protocols, no recommendation for combined non-pharmacologic and pharmacological prevention protocols. They did not suggest antipsychotics to prevent delirium because there's no evidence in the literature to support this. And they provided no recommendations for the use of Precedex to prevent delirium. With regards to treatment, their literature search showed that there was no evidence to support haloperidol use in reducing the duration of delirium in ICU patients. They found that atypical antipsychotics may reduce the duration of delirium, which we saw earlier with the quetiapine study. I'll skip the rivastigmine one. And they did not suggest using antipsychotics in patients with significant risk factors for TRISAD, which is, clearly understandable. And that in ICU patients with delirium unrelated to alcohol or benzodiazepine withdrawal, interestingly, they recommend that perhaps Precedex may be a more beneficial alternative to benzodiazepine use for sedation and to reduce duration of delirium, which again, we saw some data in the earlier studies we talked about. With regards to strategies, they basically recommend analgesia first, spontaneous awaking trials and breathing trials, promoting sleep by cutting down on interruptions, noise, and focusing treatments during specific times of the day. And they found that there was no evidence to suggest that any specific mode of ventilation would help patients sleep better and subsequently perhaps have less rates of delirium. And they recommended, obviously, an interdisciplinary ICU team approach to managing these patients in the ICU. These are all the references for the studies that we had talked about, and that's the talk. Yeah. Questions?